All right, welcome to the Duke Spine Institute. We are getting ready to perform disc surgery to repair 2 discs in a patient who's traveled from Canada. He has an L4-5, L5-S1 herniated disc. Shot. You could see that on the MRI. He's got a high iliac crest too. So I'm having a time getting past it. AP. So the first step in this surgery is to gain access to the herniated disc with a needle. And that's done transforaminally. It means from the side. So that's what we're doing. I'm trying to start as far to the side as I can because, well, quite honestly, his herniation at 5-1 is very central. Shot. Shot. Let's go, AP. I don't think you're lined up properly on the orbit. Looks like you're offset. Wow, he's got virtually very little space there. You can see that. You may have to start a little bit higher. Let's do some more numbing medicine. Shot. Shot. Lay still, you're doing all right. Well, moving target's just going to make me take longer. Shot. Lay still, you're doing great. We keep coming back. I think he's moved. That's why, Jordan. You're going to have to reposition your fluoro. Shot. AP. All right, lateral. Looks good. Shot. Interesting. I think the transverse process. Shot. Shot. That looks pretty good. Give me a AP. Lateral. How are our fluoros performing, by the way? So you're off on orbit there. Just maybe it's either, I think you're off on WAG by a degree, and you may be off on orbit too. Shot. I think it's because he moved. Shot. Shot. All right, AP. Knife. Shot. That looks good. So I'll just wait here until he's a little more awake, and I'll make my incision with the other one, and we'll get started. So we're fixing L4-5 and L5-S1, 2 discs. Now this patient has actually more than 2 discs that are problematic. He's got more that are higher up, and we were talking about them yesterday. He's going to come back and get those done in the future. It's not uncommon for people to split up their treatment. Shot? And he is from Canada, right? Shot? He brought one of his friends with him to help take care of him afterward. Shot? I met her. She's a lovely young lady. Shot? It's always good to have friends that are willing to help you in a time of need. Shot? That's a true friend. All right, any questions from our audience? Shot?
No current questions.
All right, we're ready for him to be awake.
How are you doing, my friend? You okay?
So while we get him a little more awake, and I want you guys to understand that, you know, the disc is the source of back pain in 85% of patients with chronic back pain. Chronic back pain is back pain more than 6 weeks. And in his case, he's got multiple disc herniations, L5-S1, L4-5, which are definitely causing problems. You can see it on the MRI. They're dark, meaning they're undergoing degeneration. That's from the inflammation in the disc. He also has higher up herniations at L2, I think L1-2, L2-3, right? Something like that, L2-3. But we're not treating those today. All right, Dr. B, are you almost ready?
You all right? He said, yeah. He said he's okay.
All right, let's get an AP, thank you. Let me know if you're having any pain, okay?
Just stay still, nice and still.
Shot.
You can leave your head in one spot. You can just talk, all right?
Looks good. You can see the tip of the needle is right in the mid-pedicular line at 4-5. So we're low in the foramen, away from the nerve root that's exiting. And I'm going to go ahead and advance the 4-5 needle because I feel real good about it. That's clearly a source of pain for him. Lay still. Yeah, lay still. You could see him come up. We didn't even do the discogram. Lay still, all right? Are you comfortable? Huh? Are you having any pain?
Any pain in your legs? No leg pain at all.
Wonderful news. Shot? Wait. That looks good. All right, we need your help here, okay? Don't try to get off the table. Just
Stay still.
answer me when I ask you a question, okay? Are you having any pain right now? No? Wonderful news. How bad is that on a scale of 1 to 10?
Give us a number.
How high?
8.
What's the highest it went?
8.
8. Is that where you get your pain?
Yes, sir.
All right, concordant. 8/10, concordant, L4-5. Show us the nerve root. You can see the nerve root, guys. We always talk about the nerve root right behind the disc. There it is. The dye is literally wrapping around the nerve root because it's leaking out through a big tear. And you can see that nerve root. That's going to be your L4-5, so your L4 nerve root. Is that better?
Yes.
How bad is that on a scale of 1 to 10?
What's number?
25? 9.5? Is that where you get your pain? All right, we're going to get rid of those two pain sources today. When you wake up, they'll be gone. I want you to count from 1 to 100 out loud in Canadian. Nice and loud in Canadian. Go ahead, count. Count from 1 to 100, not backwards. Hey, you said 1, 2, 3. Is that Canadian? Keep going, you're doing great. I hope my Canadian friends don't take offense to my comments, but we're just joking with him. As most of you know, Canadians, many of them speak English and some of them speak French, depending on which territories they're from, what city they're from. That's the Mexican Canadian. That's the Mexanadians. You're doing great. Lay still. So, Shot, I'm just giving him some more numbing medicine. So we know now from our test that the two discs we're treating are both causing significant pain. The top one, L4-5, was an 8 out of 10, but the bottom one, L5-S1, that was a 9.5 out of 10. And I feel pretty good about the angle of approach here. Now, I've told people before, if you've watched our surgeries, this surgery you're watching, or any surgery, it doesn't make your discs look normal. That's not the purpose of surgery. The purpose of surgery is to eliminate symptoms. And that's what we're trying to do, is get rid of his symptoms. Symptoms include back pain, Shot, leg pain, Shot, out, out, out. A lot of dye in there. But definitely a lot of inflammation. You could feel it inside the disc. So what are the symptoms that a herniated disc can cause? Back pain, leg pain, weakness, numbness, tingling. A little more. Can't really tell. Can you tell where the end of the tube is, Shot? Let's pull the dilator back a little bit. That's what it looks like to me. Go ahead. Pull the dilator back a little more. A little more. Shot. Shot. It looks like the tube is inside the disc, right? All right, good. Yeah, I agree. All right, there's just so much dye that it's obscuring the view. We're ready to do our first laser disc repair. It's called the Duke laser disc repair because it was pioneered here at Duke Spine Institute. We're the first to do it, the first to publish it. And what we're doing is we're cleaning out the posterior annular tear. That tear is full of inflammation. And because the tear has nucleus or nucleus pulposus, herniated nucleus pulposus stuck inside, it's got inflammation. Where are we? Oh, sorry. I was wondering why aren't we getting any flow? Nah, laser. Okay, we're ready to get started. Let's show our audience, Henry or Sanjay, whoever's there.
Yep.
Why does a herniated disc cause so much back pain like we just saw? Welcome back. Now you see why herniated discs are so painful. They cause a massive amount of inflammation. inflammation is redness, swelling, and pain, and heat. Those are the cardinal findings of inflammation. Redness, swelling, pain, and heat. The Latin said, rubor, calor, dolor, tumor. Rubor, of course, being red. Calor being hot or warm. If you think about it, when you have a fever, you have inflammation in your body, lots of it. And that inflammation makes your whole body hot. And there you see the rubor or redness of the inflammation. Grabber? Okay, it comes from increased blood supply to the area that is inflamed. And we're seeing evidence of that right now with this young man. He's got capillaries all around the back of the disc that are engorged in blood, and they're producing the expected result of bleeding at the back of the disc where the tear is, where the inflammation is. I'm going inside the herniated disc right now, pulling out pieces. Just about done with this one. Everything okay? I need about 2 minutes left on the first disc, then we're going to move on to the next disc. Now we're supposed to have a hurricane hitting Florida soon, right?
Tomorrow, yeah.
Is that when it makes landfall?
Yeah, well, it's making landfall tonight.
Tonight. Do you know where?
It's hitting mainly like Tampa. It's heading towards Tallahassee, Gainesville area, but we're getting it, a little bit of it.
All right. But they're not closing schools or anything?
No, they have. The Brevard County schools have been shut down for closed for tomorrow and Thursday, and East Florida State College as well.
Really?
Yeah.
Wow. Now, this hurricane was supposed to, wasn't it supposed to hit like Monday? Wasn't it?
I think it was, I think,
Slow down a bit.
no, it's actually gone faster, actually.
What's gone faster? The
hurricane?
eye?
Yeah, the hurricane eye.
What? The speed at which it's moving, or the speed at which the winds are moving? Yeah, but that's not the speed at which it moves.
You mean the translation is faster? Yeah, that's
The translation may move at 5-10 miles an hour, but the arms of the hurricane move at 75, 80, 100. The rotation may be fast, but that's what determines the type of category hurricane it is. But the speed at which it moves along land is very slow, unfortunately. That's why they cause so much damage. They literally sit and dump a lot of rain, and they just never move.
We don't have a question, but we do have a comment from Wahid on YouTube.
Wahid!
And
Hello, Wahid.
they said,
Welcome.
Dr. Duke is truly the best. Dr. Duke is truly the best of the best in the world. I just sent my MRIs for him to review. I have been looking for a surgeon like him for over 10 years.
Wahid, I'm going to cry. Your words resonate, and they make me feel pride and remorse at the same time. Remorse that more doctors don't do a better job with their patients, but pride that you've recognized all of our hard work, not just of me, but the whole team. This team makes me look amazing. They make my job easy. Thank you. Thank you. Praise. I appreciate it, and I hope we can help you. It means a lot to me when people recognize the hard work that we put in to helping people and trying to do better than, what you're told to do, basically. I had a conversation earlier today with Dr. Davis, our orthopedic surgeon, and we were talking about how, in life as a professional, you can keep doing what everybody else does, or you can try to find a better way. And obviously, I was never satisfied with the results, the average results. So I always wanted to do better for my patients and have better results for my patients so that they didn't have complications, they didn't have bad outcomes. And I feel blessed that God has blessed me and our practice to make us do a good job for our patients. So, and kept us in business, even through COVID, when it was very hard to stay in business. With, I feel like we have been looked after. So, thank you, and I hope I can help you and get out of pain. And I want to help every person on earth get out of pain. That's my goal. Of course, I know I realistically cannot achieve it, but I will die trying. So thank you.
We have a question from James on YouTube.
Hello, James.
They asked, "Hello, Dr. Duke. Question: if a patient undergoes the rhizotomy and then still has lower back pain in the lumbar of L5 and L4-5 and L5 to S1, does that mean that patient needs to have the Duke laser debriding for annular tears from a herniation?"
Great question, James. Great question. So there's, as you've pointed out, there's more than one cause to back pain. And the real trick is figuring out what each person's back pain cause is. And if you're asking me if we're 100% sure the pain is from L5-S1 region, no doubt about it, then there's only three things that can cause that. The disc at L5-S1, or the right facet joint at L5-S1, or the left facet joint at L5-S1. So there are three candidates that could be causing the pain. If you've already had, for example, the DPR, Duke plasma rhizotomy, and you have pain at L5-S1, but both facets have already been treated, then the facets cannot be the cause of pain. But if you've had a regular RFA by somebody else, then the facets could definitely be the cause of pain. Look at the herniation. You guys see it? It's squeezed out.
Yes,
beautiful. All blue. That's staining with our Duke spine dye. I'm going to grab it right now. Look at that. Beautiful, beautiful, beautiful. That's part of the herniation. It looks like it wants to tear. It doesn't want to come. Let's see if I can get it. So, to answer your question, if the pain is 100% L5-S1, but it's not the facets, then it must be the disc. There's no other source. So, what I have, though, is a lot of people think they know where their pain comes from, and they tell me, but they're usually wrong, about 99% of the time. And most doctors are wrong, and the doctors will tell you the wrong answer. So you have to be very careful. The diagnosis is so important that it's made properly. If you don't make the right diagnosis, there's not really any way you can make the right treatment. So what I say to people is, let me help you make the diagnosis. Let me look at your back. Let me look at your MRI. Let me do an exam. And I will be able to tell you where your pain's coming from. About 98% of the time. I'm not perfect, but I'm pretty good. Better than anyone else I know. and I have a lot of experience, not just with diagnosing, but treating. You see, the way you figure out if your diagnosis was right is by treating the patient. If you make a diagnosis L4-S1 disc, and you do the Duke laser disc repair, and the pain goes away, then you know your diagnosis was right, because that's the only thing I'm operating on is the L4-S1 disc. And on the other hand, if you have a patient with an L4-S1 disc pain, and you do a fusion from L1 to S1, then you fused everything down there. Well, why would you, first of all, why would you do so much surgery that's unnecessary? You shouldn't. And second of all, if you do all that surgery, then you're never going to know if the patient had just pain at 5-1 because you've done fusion of the whole spine. So I have been blessed with the ability to go in and literally treat just the area that I diagnose, like a ninja, and not treat anything else. And I see the results, and they're good. Then the better I am at my diagnosis, then the better I am at prescribing the right treatment. So doctors have to work on improving their diagnostic ability. And I'm going to tell you the secret. The secret is the physical exam. We're done.
Lights on, please.
The physical exam is the secret. And I'm going to tell you something. When I was a medical student at USC in Los Angeles, they told us, oh, the physical exam is so important. And we used to think, oh, sure, we don't need the physical exam. We have the MRIs, the CAT scans, the x-rays, nerve tests. We have everything else, all these sophisticated tests. But in the end, it turned out the sophisticated tests will never tell you, they'll tell you about cancer, they'll tell you about infection, they'll tell you about fractures, but the sophisticated tests will never tell you where the pain comes from. It's too light. It's okay, you're doing fine. So the most important test is the physical exam. And that's what I tell everybody now. Everybody. And don't forget that. It's the most important lesson. But I didn't understand how important the physical exam was until I started in my practice many years after medical school. You see, as a neurosurgeon, we rely very heavily on diagnostic imaging, like MRIs, with and without contrast, PET scan, EEG, all these sophisticated tests to give us the diagnosis. Is this patient having epilepsy? Are they having a stroke? Do they have a brain tumor? Do they have hydrocephalus? So you get these tests. The physical exam is almost useless in diagnosing those conditions. However, when it comes to back pain, the physical exam is the most important test. And the MRI is second, and the nerve test can be very helpful too. The EMG nerve conduction study. All right? That's what I can teach you. So with the physical exam, which I can do virtually now over the internet through Zoom, I can make a diagnosis with 98% accuracy. As a matter of fact, it's virtually 100% accuracy as long as the patient has the pain. The diagnosis for me is limited only by the patient's ability to show me where their pain comes from. So the problem is sometimes when I do my exam, the patient took pain medication and they no longer have the pain at that moment that I'm examining them. So when I ask them, where is your pain? They say, I don't really have the pain right now. Well, without them showing me exactly where the pain is, I can't tell what joint the pain is coming from. So I like my patients to be in pain when I'm examining them so I can see the source of their pain, if that makes sense. Wait. Yeah. Anyway, without the patient being in pain and showing you where their pain is, you're not going to make the right diagnosis. So you're saying to me, your pain is L4-S1. It could be, but If you're giving me a theoretical challenge and you're saying, Dr. Duke, for sure it's L5-S1, but it's not the facet, then it must be the disc. You're right. But if you're telling me, I think it's L5-S1, that's what my other doctor told me, then I would say, well, I don't trust your other doctor's decision. I would trust my determination. So that's what I would like to know is, I would like to examine you to verify that it is L5-S1. All right, any other questions?
Yes, we have 2 questions. This next one comes from Jerome on Facebook.
Hello, Jerome, on Facebook, welcome.
They asked, how do you distinguish between facet pain versus dysogenic pain?
Oh, Jerome, what a question. I love it. Thank you. You sound like a professional. So the way you distinguish between disc pain and facet pain, it's not one thing. It's several things. Most importantly, disc pain is usually midline, right in the middle of the back, almost dead center. Now, if the pain is coming from a tear to the right, it'll be a little bit to the right of center. If it's coming from the left, it'll be a little bit to the left of center. But typically, the pain will be localized with one finger by the patient. Exactly, is that my friend Jerome Fryer, by the way?
Yes, sir.
Yeah, the pain will be localized to the disc, and then you go look at the MRI and you see if there's a disc there that's damaged on the MRI. Very important. Second of all, facet pain is always right or left or both, but it's off center, and it's about 2 finger breaths off of center. The third thing that's very important is palpation. Facet pain in a patient, you can push on the facets 2 finger breaths off center of the spine, and they will have tenderness to palpation, tenderness. In the absence of tenderness, it's very unlikely that facet is the cause of the pain. Because, see, facet pain is from inflammation. What's inflamed is the facet joint. The facet joints are located in the back sides of the spine for the lumbar and the cervical and thoracic. So if the pain is localized to the back side and it's palpable tenderness when you touch it and push on it gently, then it means it's a facet joint. Almost 100% of the time you can make that diagnosis clinically. Again, you didn't hear me say, you know, MRI for facets, because facet diagnosis is not based on MRI. You cannot tell if somebody has facet pain based on their MRI. It's impossible. As a matter of fact, you can't tell if they have disc pain based on an MRI. You can only tell if they have an abnormal disc, if there's damage to the disc, a disc injury, an annular tear, a disc bulge, disc herniation, slip disc, prolapse disc, extruded disc, ruptured disc, slip disc. All those terminology is the same thing. It's an annular tear with extravasation of the nucleus pulposus through the tear. So it's relatively easy to distinguish between disc pain and facet pain on the exam, physical exam, but you cannot tell based on any diagnostic imaging. All right, next question.
We have another question.
Yep.
This comes from JMC on YouTube.
Yes. Do you guys need me?
They asked, what's the best surgery for spondylitis?
Well, what's the best surgery for spondylitis? So spondylitis is basically inflammation of the disc. And the best surgery is what you're watching right now, Duke laser disc repair. If the spondylitis is from an infection, this is still the best surgery. Because with this surgery, I can go in and do a debridement of the disc endoscopically. I can remove the infected material. I can clean it out. And I can also place antibiotics directly into the disc. So that, the Duke laser disc repair or endoscopic surgery that you're watching is the best surgery for spondylitis. If there is no infection, this is still the best surgery because we can clean out the herniation and the annular tear, which is the source of the inflammation in spondylitis. So itis means inflammation. Spondy means basically a disc, collapsing, inflamed disc, which is basically a degenerated disc. Yeah. And spondylitis is pretty much a degenerative condition. And this is, you're seeing spondylitis right here in this patient. This patient has spondylitis. Oh yeah, 5 minutes. 5 minutes. We're going to be done in 5 minutes. So get your questions in.
So far, no current questions, but we do have a comment from Wahid, once more on YouTube.
Hello, Wahim.
And they said, I just send my MRIs for him to review. I live in Tampa, Florida. I just can't stop talking about Dr. Duke to all the surgeons that I know. He truly is the best of the best in the world.
Thank you, Wahim.
Someone who's been involved in fitness for 41 years, 30 years of it professionally training professional athletes. Athletes really need this technology. No orthopedic surgeon wants to touch a thoracic disc surgery, and many of them discourage you from doing it. My problem is in that area, cervical and lumbar. I had surgery done by the creator of microlumbar discectomy 30 years ago in Alexandria, Virginia, but I still have pain, and it did not solve the problem. See you soon, Doc, and thank you for what you do.
You're welcome, my friend, and I appreciate your appreciation for what we do. It means you've spent time, you're open-minded, you're intelligent, and you have hope, you know, which is so important. We will fix you. I'm confident of it. First, I'll make a diagnosis. We will diagnose where your pain is coming from. Once we know the source, then we know exactly what treatment needs to be done. And as I've said before, we've done studies on our patients over the years. We found that in patients with chronic lower back pain, 85% of those patients' pain comes from a disc injury, a herniated disc, basically the annular inflammation. In 10%, it comes from the facet joints, okay? I'm not telling you a specific facet joint, but I'm just saying in general facet joints. And the reason is that it could be any one of different facet joints. The most common facet joint to cause back pain is L4-5. The second most common is L5-S1. And the third most common is L3-4. So L4-5, L5-S1, L3-4. The three most common facet joints to cause facet joint pain, which is chronic back pain originating from inflammation within an injured facet joints. As far as the disc goes, the most common disc to cause pain is the L4-5. The second most common is L5-S1, and the third most common is L3-4. Once again, you see that there's consistency, you know, in the origination of pain, whether it's disc or facet. It's most commonly L4-5, second is 5-1, third is 3-4. It's very rare to see problems at 2-3 or 1-2 further up. It's also common to see sacroiliac joint dysfunction and pain. The good news is we are now fixing that with Duke plasma rhizotomy, which is non-invasive. Essentially, it's a small 3 millimeter incision. These other surgeons all want to do fusions of the SI joints. Horribly barbaric, dangerous, invasive surgery. You don't need it anymore. We literally can fix SI joint pain with a small procedure. And finally, we're actually now treating knees and hips as well, knee and hip pain, with our plasma rhizotomy technology. All right, we got about 1 minute left here. You can see I'm looking lateral. This is the lateral herniation. Remember, we go into the disc through the tear. The tear is big. This tube, it looks big to you, but it's not big. This metal tube we're looking through is 5.5 millimeters. It's small. The tear in the back of these discs is typically 10 millimeters to 15 millimeters. Okay, some of these tears are from one side of the disc to the other. And you can see the size of this tear is quite large. And the tube is only 7 millimeters on the outside, 5.5 millimeters on the inside. This here is all scar tissue. I need 1 minute. I'm so happy for this patient because we verified that indeed his pain is coming from these discs that we're operating on. He had the 9.5 out of 10, and he had the what was it, 8 out of 10. So I think he's going to be happy. I want to see if I can get a grabber in there. There's a lot of scarred material right here, scar tissue, and maybe some herniation. I'm going to see if I can get it with the grabber. The grabber is essentially ineffective. It doesn't work well because everything is so scarred down that these grabbers, you can't really get enough force on the mouth to grab and bite and hold these herniated fragments. They're just not powerful enough. Okay? So we have to use the laser. It's very, very, very important to use the laser. The laser is the key. These doctors all say, oh, laser, blah, blah, blah. It's nonsense. Don't listen to them. All right. We are done. Look how small the tear is now after we finished. And the nerve root is right there under that fat. It looks good.
Nice on, please.
I'm very happy. We did a debridement of the tear. We removed the herniation out of the tear. And now the tear will heal on its own naturally. Look at this piece of herniation. Can you see this? I just pulled it out. Here. Yeah. You guys see the herniation here?
Yes, we do.
Okay, it just came out. Little one. It's about 6 or 7, maybe 7 millimeters. But we get a lot of those during the surgery. It's another thing. A lot of people think a herniation is one piece. It rarely, rarely is one piece. We do see them from time to time, a nice big juicy one piece. But most of the time people's herniations are small and multiple. All right, wonderful. Thanks everybody, great work. Thank you audience for asking questions and keeping me entertained. This patient's surgery went very well. He's going to go back to Canada a happy man. I'm sure of it. All done. Let me show you the incision. Thank you, Luis. As I said before, he's got pain higher up, which we're going to have to bring him back in the future, and we're going to do another DLDR later on once he's ready. All right. Let me show you the incision. The whole surgery was done through, well, today it looks like it was about a centimeter, 10 millimeters. I was a little heavy-handed with the knife, but still 10 millimeters, right? It's nothing. Any more questions?
No current questions.
All right, let's go ahead and end the stream.